Hello, my fellow people of the plant. Thanks for tuning in to another episode of the Cannabinoid Connect podcast, your favorite podcast that includes industry-facing conversations with the industry's leading experts that aim to educate and inform the public regarding the plant's endless benefits. My guest today is Dr. Jordan Tishler. He's a Harvard Medical School professor, president of the Association of Cannabis Specialists, and founder of inhaleMD. Dr. Jordan Tishler, how are you, sir?
Hey, I'm very well, thank you. How are you doing?
I'm doing great. Thank you so much for making time for me and my audience today. I'm really looking forward to, talking about cannabinoid therapeutics, which is obviously your background, right? And
Absolutely.
really talking about how these cannabinoids, marry with our endocannabinoid system and start to combat, some of the misinformation that's being disseminated, online when it comes to the efficacy of this plant. So, Dr. Jordan, before we do that, let's first talk about you and your background. So give us a little sense of who you are and what, made you become so passionate about cannabinoid therapeutics.
Sure, absolutely. Usually what I tell people is I came from a very traditional background. I went to Harvard 3 times over, which we affectionately call Preparation H. And I come from this kind of traditional, very blue-bloody kind of training, but try not to take myself too seriously.
Right.
And
Which is important.
I think so, absolutely. But there are things that I do take very seriously, and patient care is sort of that in a nutshell. And I spent a number of years working as an emergency room physician, the last 15 of which were for the VA, and that really colored my experience. It was really dramatic, the degree to which my patient population in the emergency room was full of veterans whose lives were really damaged by substances. And frankly speaking, when I say substances, what I really mean is alcohol, right? On the top 10, alcohol was 1 through 9, right? And then maybe some opioids and some benzos kind of thrown in the corner, but really alcohol is the major issue. And I got to see a lot of people over and over again, and really, come to have both a medical but also very emotional understanding of that situation.
Mm-hmm.
When Massachusetts started talking about cannabis as a medicine, I had one of those moments, you go, aha, I had seen all these guys so sick from these other substances. I've never seen anyone sick from cannabis. So if nothing else, that means at least acutely, cannabis is not as harmful as these other substances. And so, maybe if it's helpful as a medicine, it's worth entertaining what do we know and what do we not know. And that's really what drove me to spend really several years digging through the data. And it's very fashionable to say, oh, there's no data. Well, that's ridiculous. It turns out that cannabis in various forms is the #1 most researched subject on the planet. And if you go to PubMed, which is the Google of science, you find that there are over 30,000 studies. The big problem actually is, how do you weed through all those 30,000 to figure out what do we really know and what don't we know and how much is conjecture and all that sort of thing. And that took me a long time, but through that process, I really came to the conclusion that
I want to just ask you a question there. So as you were digging through all that data, and when you say it's, one of the, if not the most researched plant, I guess, holistic alternative, what was it objective, like reports that you were reading? Like, because from what I've heard, a lot of the information that was put out during, the heavy prohibition time was that it was all information that was propaganda to kind of, do the planet a disservice and really, speak badly about it. So is that what you saw, or is it pretty objective research that you're seeing?
Well, I think that you're asking exactly the right question. Some of the research is good research and objective, and some of it is bad research and tainted by a lot of bias. And some of that bias was very deliberate. Some of it is not deliberate, but simply is either the author's point of view, or it gets, manipulated in certain ways to make it to end up being very negative. I think that, one of the things we have to acknowledge is that under the sort of prohibition time period, the federal funding through the National Institute of Drug Abuse, which, where the name kind of speaks to what they're about, was very much focused on finding the harms, right, to back up the propaganda that you're talking about. I think that a great example of that is Donald Tashkin's studies on pulmonary effects of smoking cannabis that he did in the early middle 80s. That was funded by NIDA with the hope that they would find that cannabis smoking created lung cancer and emphysema and all the things that we see in tobacco smokers, so that then they could say, look, this is another reason not to use cannabis. And he found that the opposite were true, that in fact, cannabis smoking doesn't seem to create necessarily those same sorts of illnesses, though there are other studies that are also good that show that there are some pulmonary effects. And what do I take away from that? Well, what I take away from that is smoking cannabis is not as bad as smoking tobacco. It's interesting that NIDA funded something and then didn't pan out, but also that smoking, per se, is not necessarily something that we should be recommending to people, because exposure to smoke is generally thought to be a bad thing, and there are those other studies that kind of back that up. And thankfully, when we're talking about inhalation as a method of delivering cannabis medicine, we don't have to stop with smoking. Smoking is only one sort of bad example of how we can accomplish inhalation. And, I'm reaching for my props here. A cannabis flower vaporizer machine is a better tool because it allows us to control the temperature. So we end up with just medicine and none of those particles and other products of combustion that are actually dangerous for us.
Mm-hmm. It's, I got to say, I really appreciate the way you approach things in your thinking. It sounds like you're a very logical thinker, right? I mean, you're highly educated from Harvard, but like just how you assessed, your experience and kind of your introduction to cannabis and cannabinoid therapeutics with your experience at the VA in the emergency rooms, right? And you're seeing, okay, well, there's a lot of these veterans that are drinking alcohol, and that has been echoed on this podcast. Other veterans that have been on have said, the culture within the military for alcohol is like, it's celebrated, it's almost encouraged, someone said. But when it comes to cannabis, I mean, you're out the door if they find out you're messing with that, so I just appreciate your thinking in that, okay, well, this substance seems to be better option than this substance. And then it kind of led you down that path. So, as you were researching, as you were digging through the data, like, you opened up Pandora's box, right? I mean, because I can kind of say that I'm in the same boat with this podcast, talking to different experts in different disciplines of the industry. So what was your initial reaction? Like, just seeing the science behind these cannabinoids, the secondary compounds, and how they work with our endocannabinoid system?
Well, the thing that really struck me was, first of all, again, that there was a lot of research, and this is now 10 years ago that we're talking about, and things have only exploded in terms of data since then. But I really realized that, that it was sort of a political statement to say that there's no data and not a reality. But that the flip side of that is that it is a medicine, and medicines are by their nature double-edged swords, right? So that if you use them properly, they can be valuable and beneficial. And if you use them poorly or for the wrong thing, imagine using an actual sword to screw in a screw, I mean, it's just not the right tool for the thing. So, in order for us to have best outcomes with cannabis as a medicine, we have to understand when it's useful, when it's not useful, what are the pitfalls and dangers, and they do exist, which is not very fashionable to say these days. And also really think about dosing, right? I mean, and people say, well, I just smoked some weed. And to me, that's not an acceptable medical approach. We need to talk about how much did you actually inhale or ingest so that we can be precise and develop a plan, a regimen, if you will, that's reliable and effective, and also doesn't lead us to higher tolerance and therefore, down the line towards cannabis use disorder. And I said, I have to say, it's really not fashionable at the moment to talk about the downsides of cannabis, but that's really an important part of acknowledging the benefit and putting it sort of in its right context.
It is. It's very important. And with this podcast, I always want to be objective, and it's important to talk about the adverse effects of cannabis use. You mentioned, the term cannabis use disorder. So, Dr. Jordan, why don't we start there? Let's talk about, how this external substance can be abused and what some adverse effects can be. And then we'll switch over to, the obvious benefits that we hear also.
The thing about cannabis and its risks are that they're seemingly mild compared to many other substances that we're more focused on, like opioids and alcohol. And I think there's truth to that. That is to say, if you take too much of an opioid on day one, it's quite possible that you'll stop breathing, and that's sort of the end of the story. And that simply won't happen with cannabis. But what I do see in my patient population, and this drives me bananas, is that patients can come to me and we work out a plan and it's working and they're using it and they're getting benefit and we're keeping the dose low and their tolerance is reasonable. And then something comes along, and that something is usually advertising from the industry, the dispensary groups, that then kind of pushes them gently towards using something else or something more, oftentimes a more highly concentrated form, whether that might be adding a little keef into their flower or something like that. And then these kind of little baby steps down that tolerance road start to add up. And suddenly, I'm seeing a patient 6 months later, and they went from using, 5 or 10 milligrams once or twice a day to now they're, ingesting who knows what because they've stopped keeping track. And when I estimated, we're talking, 50 or 100 milligrams, and that can get out of control quickly.
Wouldn't the tolerance naturally go up as they use, though? Like, or I get your point
No,
about the dispensaries marketing more, because we're seeing that trend in Colorado. The higher the potency, the better, which is not necessarily true, but like naturally our tolerance level doesn't increase as we use.
no, actually, and I think that that's a really important point, that there is a sweet spot. And in that sweet spot, we're getting the benefit from the cannabinoids, but our tolerance is stable. So I have many patients who are, again, on that sort of 5 to 10 milligrams range. And if they keep doing that, everything's fine. They keep getting benefit, their tolerance doesn't go up, they don't need to add more. But what can happen is you get past that sweet spot, and then you get this kind of a snowball effect where you use more, you need more, you use. I mean, that kind of a snowball, in my mind, even really kind of partially defines problematic use. But at that lower level, it's really stable. And I think that's a key point. So if we're doing this properly, we can get the benefit without that kind of ever increasing demand that leads to problems.
What are the adverse effects of continually using and increasing that tolerance level? Like, where does that lead?
That's a good question. So tolerance in and of itself isn't necessarily a bad thing, but it's when tolerance starts to accelerate that it becomes a problem. And if, here's the way I describe this to people. you've mentioned the endocannabinoid system several times. So for your listeners, just a reminder, so we have these signaling systems in our brain and actually throughout our body that we call the endocannabinoid system. And what's going on there is that certain cells are sending a signal with our endocannabinoids, these chemicals, to other cells that have receptors. And I'm putting my hands up because I think of the receptors kind of like those little satellite dishes that we put on the side of our houses if we can't get, cable, right? And so we have a whole bunch of those things. And in theory, those things are in a certain amount of tune or balance, right? That there's a certain amount of these endocannabinoids that are coming across and a certain amount of receptors that are there to receive the signal from those chemicals. When we start adding the phytocannabinoids, the cannabinoids from the cannabis plant, we're stimulating those receptors. But if we overstimulate them, then our body's reaction is to simply take away some of those receptors, right? It's a way of turning down the volume. And that's okay. It's an adaptive response to say, oh my God, I'm being flooded with this signal. I need to turn down the volume. So they bring down these receptors. The problem then is, in the more extreme cases, then there are no longer an adequate number of those receptors in place to hear the endocannabinoids, right? So you become dependent upon the external cannabinoids to provide that signal, which means if you stop those phytocannabinoids, you don't have enough reception and you end up having consequences like withdrawal. Mm-hmm. Now, granted, in cannabis withdrawal is not the end of the world, but there is a strong drive not to withdraw and not to cease the cannabis use. So we can get then into that vicious cycle where if we use more cannabis and we take down more of those receptors and then we need more cannabis, you can see how that becomes that snowball.
Sure. Yeah. No, that's a really great way you put it. I'm a visual kind of thinker. So that was perfect. So one other follow-up question to that, does our body naturally reproduce those receptors?
Yes. So it's an adaptive process, meaning that if we lower the flood of phytocannabinoids, and notice that I said lower and not eliminate, then it will say, oh, okay, I need more receptors, and it'll put more receptors out there. And so, in the stoner community, people talk about tolerance breaks, right?
Tea break. I was going to ask that. Exactly. Yes.
Right. And that's exactly what's happening. They say, all right, let me take 2 to 4 weeks off, and then, the cannabis will work better and I will need less, and that's good for my wallet. And that's exactly what's happening is when you stop the cannabis, your brain goes, oh, I don't see so much signal anymore. Let me poke out my antenna and see what's out there. The problem when you're talking about medical patients is that the concept of tolerance break is much more complicated, because you don't want to take somebody who has a medical problem and simply take away their medicine and go, for the next month, you're on your own, ha ha ha, right? I mean, that's just not kind.
Right.
So it's actually much better to gradually decrease the exposure, and over that same period of time, the receptors will then get re-emplaced, and that's good, but it's slower and it really requires a certain amount of buy-in and discipline on the part of that individual, and that can be tough,
Sure.
It requires that person to understand that they're on a path that's leading in a wrong direction, and to make a commitment to sort of reversing that. And with all of the misinformation, out there on the internet that we've kind of talked about, there's a strong push that, cannabis is good for everything and there's nothing wrong with using more and all that. And that's bolstered by an industry that makes money on selling more and more cannabis. So, we have some working that out to do.
Right. There's a fine balance, right? And just with anything, right? I mean, any external substance you don't want to abuse. One other kind of topic within the adverse effects subject is this ailment, or what it called, cannabinoid hyperemesis syndrome. And we've heard about it because of how many people are flooding in the ERs because they cannot stop vomiting. and getting dehydrated and whatnot. And so what is that about, Dr. Jordan? I mean, is that just somebody's body chemistry that's not reacting well to the cannabinoids? Is it inhaling by smoking as opposed to other consumption methods? Like what triggers that?
All reasonable, good questions, most of which we don't really understand at this point. I tend to think so. First of all, it's very clearly an individual response, but it's also found not in newbies, right? It's found in people who have been using cannabis over a long period of time, and usually fairly heavily. Why there's a change from this is a good thing to this being harmful for those people, we don't understand. One of the things we do understand is that cannabis at lower doses can be useful for people who have nausea and vomiting, right? So there's clearly a way in which the cannabis gets into our system and affects sort of the nausea vomiting centers of our brain. One can imagine then that, as with every double-edged sword, a little bit may be helpful and a lot sort of pushes things too far, but the mechanism of that is still not really understood. I also think that we have to recognize that, a couple of things about cannabis hyperemesis. One is that I think it's being overdiagnosed at the moment, right? I mean, that is to say, with all of the discussion about cannabis, particularly in states where it's now recreationally legal, like Colorado and Massachusetts, I think that there's a tendency for my grumpy ER colleagues to say, well, he's using cannabis and he's vomiting, therefore it's cannabis hyperemesis. And I think
Right.
that that's not fair, and my more thoughtful ER colleagues are probably, not falling into that trap. So I think we're probably over diagnosing it. And then the other point I think is worth making a point about is unfortunately, if you actually do have cannabis hyperemesis syndrome, that is unfortunately a lifelong diagnosis, which is to say that the only treatment for cannabis hyperemesis at this point is to stop using cannabis. And in folks who then restart after some period of time, they don't get very far down the cannabis road before it comes roaring right back. It really doesn't kind of go away. So if you actually have cannabis hyperemesis, you're going to have to come to terms with ceasing your cannabis use.
Mm-hmm. That's good advice. And it's just so interesting. And, I look forward to learning more about that particular adverse effect, because, I personally know people who struggle with it, last question to wrap this part up, and then of course let's talk about the benefits.
Sure.
Is Mythbusters. Let's play Mythbusters here. So when I was right out of high school and I was starting to consume cannabis more, I would always hear this myth about if you're smoking weed that has seeds and stems in it, you could become sterile and not have babies as a male. Is that true?
No.
Or cannabis itself, does it do that or not?
All right. So the weeds and the stems and seeds part is not true and somewhat ridiculous. Actually, that's a myth I had not encountered. Sorry that somebody said that to you. But in fact, there are not a whole lot of cannabinoids in the twigs. There are a little tiny bit more cannabinoids in the seeds. And in fact, there have been cultures that have used the seeds both as a foodstuff, but also as a way of, to vaporize. They sort of essentially take the seeds and put it on a hot rock in their home, and it creates a vapor, hotboxing the house essentially.
Right.
So no, the sterility from that is a ridiculous idea. To the question of can cannabis itself have any influence on reproductive health, the answer to that is a little bit complicated. We have reasonably good evidence at this point that cannabis can decrease sperm count, and it can also cause sperm to come out sort of funny looking. And funny looking means it doesn't swim as well as it should. So sperm numbers and sperm motility can in fact decrease. And that's visible under the microscope in the laboratory. But then the flip side question is, well, yeah, so how does this affect things, right? I mean, it's easy to find something in the lab. The question is, what is it doing in the real world? I think it's fair to say that we can all acknowledge that there doesn't seem to be a great fertility problem amongst stoners.
Right.
Right. And so most people's semen contains so many million sperm that if we knock 20% off that, there's still plenty.
Still plenty to go around. Exactly. Yeah.
So I think that, there's a little bit of a gap between what we can observe in the lab and what its consequences may be in the real world. I think, if somebody came to me and they said, Doc, my wife and I have been trying to have a baby for, 6 months and it isn't happening, then I would say probably you should come off cannabis and see if that makes a difference. I can't say that it will, but when, we get into those situations where there are a lot of unknowns and there's a lot of emotional steam, then it's probably a good idea to eliminate whatever variables we can.
Sure.
And that's the same argument I have. I know there was an article that came out a couple of years ago about bud tenders in Colorado recommending cannabis as an anti-nausea medicine to pregnant women. And I think that we physicians generally think that's not a very good idea. The data on what happens during pregnancy if cannabis is used is very mixed. There are a bunch of studies that look kind of bad, and then there are a bunch of studies that look kind of like, well, maybe it's a no big deal. But until we know more, I think the prudent thing is not to do it, because if nothing else, if something were to go wrong with that pregnancy, which affects not just this child and the mom, but also the dad and all of the extended family, and there's a lot of people whose lives are affected and a lot of opportunity for feeling bad and finger pointing and all of that sort of thing.
Right.
So simply eliminating points of controversy, points of concern, things that people can worry about and look back on and say, well, why did you do that? I think there's value in that, even if we can't yet prove that it is or isn't sort of a physiologic problem.
Right. Okay. We cleared that up. And last Mythbuster question is, does cannabis affect your ability to have dreams? Obviously, we all dream, right? And we forget what we've dreamt, but does it inhibit that kind of part in the brain where you're not dreaming as much as you would if you weren't consuming cannabis frequently?
So the answer to that is a yes and a no. So it's dose dependent. So if you look in the sleep literature from 20 plus years ago, what you find is that people's sleep was in fact disrupted and their dreaming was disrupted. The problem with those studies was that they were all BYOC, right? So the researcher would say, thanks for coming in today, and go out there in the back alley and use the cannabis. We don't want to know anything about it. Come back when you're done and we'll watch you sleep, right? Which meant that we had no idea of what people were using, and it turns out, most importantly, we have no idea how much they were using.
Mm-hmm.
More modern studies where we have found ways to sort of to control or estimate how much people are actually using show that lower doses lead to better sleep with continued dreaming. So again, dose is the key factor, and low dose is benefit, but higher doses can be disruptive. This is a theme I think that you're hearing.
Right.
Right.
It comes down to dosing, right? And understanding what exactly we're consuming, because the secondary compounds, the flavonoids, the terpenes, all those play a factor into, how that reacts with our body chemistry, is what you're saying.
Well, what I'm saying is that the dose of the cannabis matters. And we tend to measure that in terms of THC. Mm-hmm. I do believe that the entourage effect that you're alluding to by talking about terpenes and flavonoids is is likely to be real, but I think we don't really have much of a handle on sort of which parts are actually having an effect versus which ones are kind of along for the ride. And that's part of what I think the next phase of research really needs to address. Very clear, from a range of studies, including some of the cancer studies that are being done by Professor Mary in Haifa, Israel. You can show that certain extracts of cannabis kill certain cancer cells and not others. And so that means that there's something about both the extract and the particular tumor that's specific. And it's therefore not just as simple as THC or CBD. There's other stuff in that brew. And what they're working on is figuring out, okay, well, we kind of know the obvious players, but what are the less obvious players? And if we think about cannabinoids and, estimate that there are about 140 of them, it's my sense that they're not all important, but there's clearly more than just 2, 3, or 4 of them that are important. So we need to kind of get in there and chip away at that puzzle until we've kind of figured out. It may be that there are only 3 or 4 of them that are important for particular illnesses, but we got to get the right 3 or 4 for each illness. And that's going to be very exciting research, to come.
Right. Absolutely. Yeah. And especially with, I think I read an article that the DEA is now allowing for certain institutions to do more research when it comes to the efficacy of cannabis. Because before it was just set to one institution. I think the University of Mississippi was the only one that was granted
it's
that.
not that they can't do the research. It's that they can. Previously, only the University of Mississippi could grow.
That's right. Yeah.
And there were some issues around whether people felt that the cannabis that was being provided from the University of Mississippi was good enough quality, or in other ways sort of mirrored what people were getting, at the dispensary, right? I mean, it doesn't really do us a lot of good to do a good research study using cannabis that isn't reflective of what people are using in the real world. So what the DEA has done now is they have opened the process to other growers, like dispensary growers, so that the products that are used in the research are more representative. The flip side, and the reason I'm sort of not like jumping up and down with joy is simply that the DEA continues to control this stuff pretty tightly. So that while, yes, in theory, you could, as a grower, get, to supply research, the process is lengthy and costly, and it remains to be seen how well that's going to actually work.
Right. Yeah. I would imagine there's tons of hurdles and hoops to jump through, because of the fact that it's still listed as a Schedule I narcotic.
Ultimately, I think, one key point is that I don't think the police should be in charge here. I'm not saying I don't believe that police are necessary, but I think that the org chart of our government puts the DEA over the FDA, and it should be the other way around. I think the DEA ought to be an enforcement arm of the FDA rather than sort of having administrative control over things like the scheduling of substances. But that's just me, and I realize that I am biased as a physician scientist. So.
Sure. No, I think that makes sense, though. I want to ask you, so let's switch to the efficacy now, right? And while it's clear that June is Pride Month, June is also PTSD Awareness Month. And, you mentioned earlier in the episode that, you have experience working with the VA in the ER, and you saw many veterans who were dealing with a lot of different things, and they were leaning on alcohol as kind of an alternative or an escape. And so tell me about how cannabis, can address PTSD in your experience, and maybe other ailments.
Sure. So PTSD is a very pervasive and nasty syndrome. And we're fairly limited in our abilities to treat it at this point. So I think that cannabis really opens, another useful avenue. And cannabis can be used, again, in low doses to control aspects that include things like the hypervigilance and the easy startle that PTSD people suffer from, as well as sort of generalized anxiety, difficulty sleeping, and the nightmares that are often associated with that. So, you know, PTSD is a syndrome, meaning it's made of many symptoms and complex pieces. Not everybody has all of them, but the nice thing here is that cannabis can be useful for many, if not all of those pieces. The flip side of that is, again, that low doses are effective and higher doses can actually backfire and make things worse. So we want to really focus on the dose, and we also want to focus on the timing. You know, and in the community, there's a lot of discussion about treating anxiety, for example, with sort of the wake and bake philosophy. You know, you get up in the morning, if you're feeling anxious, you light up, and then sort of throughout the day, you continue to smoke cannabis to keep your anxiety at bay. And we actually have good research to suggest that that's not the best approach, that under those circumstances, number one, school and work performance can fall off. And number two, that anxiety and depression actually can become worse. And you can actually get into a vicious cycle where you use cannabis to treat anxiety, but it actually then provokes anxiety and you can go around that wheel. We don't want that. But again, low dose delivered typically in the evening time can be very effective for calming anxiety, helping with insomnia, maintaining reasonable dreaming, and also sort of counterintuitively can be helpful for anxiety throughout the next day, largely because it's not the intoxication necessarily that's causing the relief, but it's the interaction of the cannabis with our neurology that is doing so. Another thing I want to point out, you know, unfortunately going back towards the harm side of things, is that there's been a fair amount of research done, well done, particularly by a group at Johns Hopkins, that has shown that in the veteran PTSD population, they often go from sort of no use to problematic use very, very quickly. And I think a lot of that has been because they tend to get their cannabis medical advice from their buddies more so than from a clinician. And so there's often more of a more is more approach as opposed to a less is more approach. And so we can see people going from no use, and the numbers are really astounding, up to 12 grams a day. That's 12 ounces a month, you know, which is clearly excessive and ultimately will be harmful. And so for me as a clinician, when I'm treating folks who have PTSD, I always really work with them to pay particular attention to making sure that we're being methodical and consistent about this. Mm-hmm. And then under those circumstances, I've had remarkable success.
Right. Yeah. I mean, that totally makes sense when you go back to being methodical, making sure that you're dosing properly and being consistent with that. And so, you know, if we look outside of the veteran community and we look at, you know, data that suggests that people are kind of moving to cannabis, and COVID's a perfect example of that, right? I mean, that was a time where there was heightened anxiety, depression, and you know, the data showed that the consumption rates of cannabis were almost equal, if not surpassing alcohol consumption. So I guess that kind of validates everything that you're saying.
It validates two things, the positive and the negative, right? I mean, that is to say, we saw people develop anxiety and depression, and the acceptance of cannabis is now at a point where many people then went to treat their anxiety and depression with cannabis, and hopefully most have been successful. But the flip side is, particularly in recreational states, what I'm seeing now is people coming in saying, you know, during COVID, I was feeling anxious, so I went to the store and I bought some weed, and now I'm still feeling anxious and I'm using a whole lot of cannabis and it's not really working for me. So what do I do? And then I sort of, you know, work with them and figure out that they've gotten themselves into a place where cannabis is actually part of the problem, and that they're on that path already to misuse, that's much harder for me, right? Because imagine if somebody comes to me and they're not using cannabis and they say, I have anxiety or PTSD, then being methodical, we're starting from zero, so it's easier.
Mm-hmm.
Whereas when I'm getting people who come in and they say, I'm all over the map and it isn't working and blah, 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 then it's much harder to kind of bring that back under control and funnel it down into something that's both safe and effective. So in many ways, as a clinician, I'm happier with the first scenario than I am with the second, and it is going to be a downside of recreational legalization, that there is this kind of self-medication DIY thing that I think may backfire for a lot of people. And it's one of the reasons why I think that, first of all, I'm absolutely for recreational legalization. I think that this is something that people should have a right to do, but I don't think that it should be done for medical purposes in a DIY sense. So, the classic example that I give people is, look, if you're somebody and you go into a dispensary and you ask the question of the bud tender, what goes well with fish I'm serving on Saturday night, I think that's a perfectly reasonable discussion and very analogous to going into the liquor store and asking for, their recommendation on a Cabernet Sauvignon, right?
Mm-hmm.
I think that's fine. But if somebody goes into that dispensary and says, what have you got that's good for my backache? This dispensary really should be in a position where they say, look, this is a medical question. We can't answer medical questions. Here's a list of physicians in the area who can help you with this. Why don't you go talk to them and come back when you have a regimen or a prescription in place from them, and then we'd be happy to provide that for you. And I think that the industry at the moment is not going to go in that direction unless they're regulated to be required to do that. So
Mm-hmm.
that's where I'm thinking.
And I understand that. And when I hear you talk, I know that, and it's so important. You're focused on the, like you said before, the methodology, being methodical, properly dosing and being consistent. And we talked earlier about strain variation, secondary compounds, cannabinoids that we're still learning about, and how they interact with our CB1 and CB2 receptors, as you talked about earlier. So with that part of it, the variation of strains, that we're kind of putting that on the back burner, but just because we don't have that knowledge, we don't have that research yet. Is that right? I mean, because I would imagine that plays a big factor as well.
I think that we all think it will, but we don't have the evidence to prove it and to figure out, which are the important bits for what circumstance. So again, I think that that's really interesting stuff that's coming rapidly down the pipe. Ultimately, so, on the strain side, the interesting bit for me is that there's a lot of discussion about different strains. Clinically, I find them all to be the same. That people may say, oh, I like this one or I don't like that one. But when you ask the question, did it help my back pain or is it helping with my insomnia? I'm not finding differences that are clinically meaningful.
Right.
That doesn't mean that different cannabinoids or other compounds won't be differentially important, but that they're not represented in these strains in sufficient quantity, or they are there, but they're also sort of counteracted by other things that are there. So in my my crystal ball suggests to me that while strains, I think, will not turn out to be super important, understanding those cannabinoids and the combination will be hugely important, and that will lead to other medicines, presumably pharmaceutical type medicines, that use those compounds combined together in very specific ways, say to address nausea or to address insomnia or even PTSD. I just think we're not quite there yet.
Right. No, that's totally fair. And what's interesting when we talk about specific cannabinoids is, the biggest loophole, I would say, within the hemp industry, and that is Delta 8. We know that it's a synthetic cannabinoid because it is converted, the CBD is converted into Delta 8 THC. So from your standpoint, Dr. Jordan, is there any medicinal value to Delta 8? I know that some people online say that there is, others say that there's not. States, I think up to 14 now, have banned the cannabinoids. So what's your take on Delta 8?
Um, I think Delta 8's primary value is that people can, sell it. To be blunt, I think that this industry is scrambling around to find things that they can make into products, and unfortunately at the moment have free reign to sort of say what they will about it. Truthfully, I think that, if we had isolated D8 and we could test it, it probably functions fairly similar to D9. There are really no studies where we're looking at D8 that doesn't also have D9 in it, right? Cannabis itself has a lot more D9 than D8. It often has some D8 in it, so it may be responsible for some of the effect and benefit from regular old cannabis, but we can't tease apart which is coming from where yet. I think, its legality, I think, is pretty gray. I think the Controlled Substances Act very specifically bans THC and not specifically Delta 9 THC. But the industry is really trying to kind of find the loopholes and to say, oh, well, this came from hemp, so it's okay. I think that's actually legally accurate. What I don't want to see is people going off and buying D8 because they think it will be effective when we don't know that it's effective. And I don't want people going out and thinking that they can buy D8 because it's safe, because we don't know that it's being produced in a way that is safe. And that synthetic pathway, if done improperly, can leave impurities that we don't want to ingest. So I think that there's more to be written there, but it isn't the solution to the problems.
Right. Yeah, I recently had Latal Shafir on. She's the head of product at Leaf Report, and during our conversation, she mentioned that they were conducting a study and they were about to release it on Delta 8, and kind of, because they're a science-based company that researches the efficacy of CBD products, and their whole study was focused on Delta 8. So I'm going to have her back on and talk about those findings, which I think they already issued the press release. And, a lot of it wasn't encouraging, and it's not surprising, I think, right? Because to your point, it's the wild, wild west right now, and people are just scrambling to kind of, make a buck when they're not necessarily thinking about the efficacy or maybe the harm it may do to the consumer.
My take on that is that the smartest groups, companies out there are going to take a longer view, and we're not seeing that yet, but I'm hopeful that it will evolve. Right now, as you say, everyone's scrambling around trying to make a buck, and ultimately those people are going to fight each other to the death, and that's not going to be good for the industry itself. But if people look at the history of the pharmaceutical industry, they are a very tightly regulated industry and still make boku bucks, right? So it's quite possible to do this for the long term in ways that generally are focused on helping people and patients, and within the context of greater rather than lesser regulation, and still make plenty of money. So I think that we need to get to the point where the companies that can think that way down the road and prioritize patient safety as well as efficacy over the quick buck, those are the companies we need to float to the top, because they're the ones that are going to really represent what this industry is capable of after that sort of initial shakeout where everyone's just trying to make a buck, selling whatever.
Right. Yeah, no, I couldn't agree more. Dr. Jordan, I want to give you the floor now. I know that you're the president of the Association of Cannabis Specialists and the founder of an inhaleMD. So why don't you talk a little bit about your role within those two entities and what the mission is?
Well, let me start with my practice, which is inhaleMD. So when I was working at the VA and studying cannabis medicine and coming to the conclusion that this was a valuable resource, As you can imagine, the VA sort of didn't want to hear about it. In fact, my poor boss really turned green when I mentioned this to him. And in fact, this question of what it meant to the VA went all the way up to the lead counsel, who said, well, as long as he's doing it on his own time, no big deal. So that was good. But it made it very clear to me that I wasn't, 10 years ago in a position to sort of influence policy at the VA.
Right.
All because of the federal prohibition. And then I looked around and said, well, I'm on staff at the Brigham Women's Hospital, which is a large private hospital, and they get all their money from the feds too, so they're not in a position to do it. So it led me to private practice. I was not particularly interested in private practice, but that was the way to do this so that I could take care of patients, and perhaps even equally important, I would never say more important, to go back to my colleagues in all of these institutions and say, here are the data, here's what we know, here are how patients are doing and stuff like that. And that's really been the basis of this phase of my career, taking care of patients one-on-one and teaching my colleagues, in the broader context. That led me to form the Association of Cannabinoid Specialists. We used to be Cannabis Specialists, but we've changed the name to Cannabinoid Specialists to kind of broaden the thinking past the plant material and into sort of the greater scientific context. But it became very clear to me that there were docs, and not just docs, but other clinicians out there, nurse practitioners, et cetera, who wanted to know this kind of material, but didn't know where to turn to get the kind of education that is really both clinically relevant and also very much driven by data and not, lore or preclinical data, mouse stuff. And so we really developed an educational agenda and curriculum around making sure that people really understand the science, but also then understand how to translate that science into stuff that they can action with their patient one-on-one when they're sitting with Mrs. Jones. And I think we've been very successful at that. The other part of the educational agenda is that we want to make sure that all the other docs that are out there or other clinicians that are out there who are not interested in doing this medicine understand enough about cannabis to know when it would be helpful and when it would not be helpful, so that they can respond to their patients when they're seeing them and refer those patients to a cannabis specialist when it's appropriate. So that's what I call those referring clinicians. And then, of course, we've also developed a political advocacy mission, because what we're seeing is that the industry is focused on that fast buck, and even policy in DC, where we're hopeful that things are going to change, may change without any thought to what this means for patients. Right now, if you listen to the rhetoric coming out of DC, particularly Senator Schumer's office, you hear a lot about legalization, which is really good for the industry, and even some talk about social justice for communities that have been disproportionately policed around this. And we certainly agree that those things need to be addressed, but there's absolutely no discussion about medical cannabis, which affects a much, much larger and at the moment much quieter population. Really, I mean, there are 180 million Americans over the age of 55 who will, not may, will develop one or more conditions that we couldn't treat with cannabis. So we really need to make sure that those folks are accounted for and provided for in this legalization process. And right now there's Zippo discussion. So we have a lobbyist, we're working hard on trying to get this issue to bubble up in front of the lawmakers, so that we end up with a comprehensive package that's not just good for sound bites, but is actually good for all people, especially patients.
That is a really good point. I didn't think about that, and you're totally right. There's so much discussion about legalization and the restorative justice, social equity component, which is, of course, is super important, but zero talk of the medicinal side of it, the medical patients that need this medicine. And when Schumer talks about, quote unquote, this bill being comprehensive, I mean, I would imagine that the medicinal component should be added in that.
Yeah, I think, I think comprehensive is kind of a tough word to use if you leave out the largest
Right.
potential group, right?
Right.
But let's acknowledge the fact that the recreational users have a lot of organization behind them, whether we're talking about normal or DPA or MPP, right? And then the industry has a lot of organization and money. So there's a lot of lobbying going on, and I've talked to a number of very high profile CEOs over the years who have said, oh, well, we don't really need medical, right? What we need is recreational. And then anybody who has something wrong with them, can come to us and we'll take care of it. I'm just thinking that's a nice fantasy, but look at all of the discussion we've had today about, the ways in which this encourages overuse and the harms that can lead to. It just needs to be viewed, in my mind, as really two separate things. If you're a well person and you want to party on, whatever, then, recreational is fine and should be available. But if there's, something going on with you where you're not well, that really should be addressed in a more knowledgeable context than just going down to the barista or bartender and saying, what do you got, dude? So I think we've got to sort our way through that, and I'm hoping again that the industry will come around to understanding the value to them and to their bottom line of being a good actor in this process of having clinicians direct care and they fulfill the medication that's necessary.
Right. Yeah. I mean, I'm hopeful that we're going to move from that bro science that you're talking about, to more legitimate, science-based, pharmaceutical practices when we're dealing with cannabis, and all the work that you're doing with the Association of Cannabinoid Specialists and your own practice and inhaleMD. It really takes that holistic approach of education, as you mentioned, helping the clinicians navigate through this since it's new for them, and then the lobbying and the political side of it, and voicing the concerns for the medical community, because it's so important and it needs to be included in that comprehensive bill that Schumer's talking about. So Dr. Jordan, I really appreciate your time. Is there anything that you want to leave the audience with before we wrap up?
Well, I think that one thing I would say is, as you can imagine, all that lobbying and getting in front of the senators takes an awful lot of money. And because we're a professional group, we have fairly limited funds, right? It's not like we're backed by the cannabis industry. So if any of your listeners happen to have a few extra bucks and want to support us, that would be lovely. They can go to our website, which is cannabis-specialist.org, cannabis-specialist.org. And there's a donate button at the top, and we certainly appreciate anything that anyone can contribute to our efforts on their behalf. And then, if there are people out there who are feeling sick, let me say, look, we do telemedicine exclusively. I take care of people all over the world. And so if any of what I've said today resonates with anybody and they want to talk to me on a professional basis, then they should absolutely reach out. And that website is inhaleMD.com. Again, inhalemd.com. It's really easy to reach us through the website, and be happy to help take care of you.
Perfect. And I'll be sure to get with you after this recording, Dr. Jordan. I'll get those links and include them in the description box here for YouTube.
Thank you.
So yes. Well, thank you so much again for the insights. I know that I got a lot from this discussion, and I know that the audience did as well, Dr. Jordan. So as things evolve, I'd love to have you back on the podcast and dive deep more into this.
Thank you. This has been a lot of fun. Actually, the Delta 8 study sounds really cool, and I'm interested to see what they come up with.
Absolutely. Yes. Well, thank you so much again. And thank you all for listening. Bye.